Okay. So the session was named as Grand Rounds with Experts. So you can see all the stalwarts of arthroplasty are here. So we'll try to bring out as much as points out of them. So quick housekeeping rules. I think almost like 30 minutes or 40 minutes. I don't know. Let us be short and crisp with the discussions. We shall try to bring out some good learning points. 63-year-old female, TKR done outside, and this is the immediate post-op, 5 months follow. Sir, 5 months follow. Oh, you want from that side? Okay.
So it has failed due to instability.
Yes. So to help you with the scenario, this patient comes to you in 5 months' time. What will be your plan of action? What will you tell the patient and what will you do?
So I'll counsel the patient that we need to revise the case.
So you will, at this stage, you will revise.
Yeah.
That is your point.
Yeah.
Dr. Bose?
Yeah, I will take stress views for sure. Then that will tell me how to proceed. And the infection, of course, also you got to keep in mind. Yeah.
Yes. So you will take stress views. Dr. Hari?
I'm sorry, you'll take what views?
So now the point is.
Varus and valgus stress views.
Okay, so he is going to say, he is going to take stress views and it is available with you. So at this stage, you will intervene or not?
Well, I think the first thing is make sure there's no infection.
It is not infection.
I don't need a stress view, I already know.
So you're not going to take a stress view.
I
Okay,
mean,
so
she
what
needs
will you do
work
now then? Without stress view, patient is having pain, coming here, but walking, what will you do? Only question is whether you will intervene or not at this stage.
Definite operative intervention.
What is that?
Definitely to the OR.
So you are going to intervene. So what will you tell the patient? What is your implant or what is your plan if you are intervening?
So my first question is, are the components stable? And I suspect they may not be, the tibia may not be, and I'm not convinced that the femur is okay too. So at the very least, I might get very lucky and just rebalance the knee with a poly, which I doubt. This is probably at least a single component revision.
So this is a CR. So you are going to again try for a CR, different insert, thicker insert, and see if it is going to be stable. Is that your plan?
That is one plan. If you have that ability for an AP constraint or a deep dish CR, that would be one option. Clearly, there's an imbalance here, so we have to address that.
Okay, Dr. Mahajan, anything
Can
different?
you go for previous X-ray, one X-ray before, please? Okay. It doesn't seem anything grossly wrong there. Of course, on rotation of the tibia, but I don't know. Maybe she had a fall, something, any injuries?
No, Paul.
No. I think it looks like she has a ligament imbalance. Needs to get a stress X-ray. See whether you can arrange with a deep dish. If not, go for a full-blown revision. Yeah.
So the only question why I put up here at 5 months follow-up is whether to intervene here in this stage or not. So that should be the point here. So will you intervene
Yes,
here?
yes.
So you will also intervene. Sir, Pachori,
You can't.
final.
Before confirming this, I would like to get the actually implant, what implant were there? Size,
CR.
Yeah, CR.
CR.
CR, but size, what are the size and other things are used. So you need to keep the inventory ready, that is one. Second is, I'm for a little bit of CT scan because I want to also see the femur rotation also so that I'm not missing anything.
So good points here. So to sum it up, you need anything like this. You need a varus valgus stress view. You need to know the implants, what has been used, get the discharge summary. So, and if at all you are planning, you have to have the whole inventory available because if you are going to retain the implant, so that should be this thing. So so the patient at 5 months went to the surgeon didn't do anything. 9 months later, this is what? Sir, now at this stage.
So there's been a iatrogenic lateral side injury for sure. And because they have left it like this, now I think with so much of laxity, looking at a hinge, and nothing short of a hinge in my opinion. Also, when we say now, when you do a revision for instability, I think a deep dish is insufficient. That's my opinion.
That is,
You cannot, it's fine for primary, but you are doing a revision, especially for instability, you cannot depend on that. So, if I do revision, PS would be the minimum I would go for. This I would need a hinge for that. This would be my plan.
yeah, that is what I actually wanted to project here is it's a CR implant. So we, in a ligamentous instability, when we are trying to retain a CR implant, we have to be very cautious. Maybe in Dr. Hari's place, he will have all the other options of deep dish and all those things, which is not very easily available in India. So you have to be very careful. Any sort of ligament instability, the outcome is very, very bad if it is not properly addressed.
One point. No one should start thinking of imbrication or application or anything of those sorts. It doesn't work. So I think that's a very clear message. Should not be trying all those things.
Yeah.
Thank you.
So that is where patient came and you can see that.
So what could be the reason for this failure? I fall.
Either fall or peroperatively something happened at the time I was doing surgery. Yeah. It's not.
So this was the perioperative examination. You can see how much of instability. It is a CR implant. This is what, and after removal of the implant, then I did the hinged processes. So I didn't think of anything else because of the gross instability. So this is a 2 years follow-up. So in a majority of the revisions, having used a hinged here, majority of the revisions, consent process like a PFC, then a TC3 like a CCK, sort of the next level of consent should be the first choice. And if not possible, then you are using a hinged, please always use a rotating hinged knee in a gross ligament instability. So third generation rotating hinged knee gives you very good result. So that is the take home message of this case. 20-year-old female. Sir, Pachori sir.
Yes, any other views, any other markers,
so
markers?
this
This is a destructive pathology.
Okay, so in this scenario, all the blood parameters for infection is normal. So 21-year-old female, what will you do and what is the implant choice?
No, I must think of first what is the diagnosis of this patient before embarking on anything. Because why should he have a unilateral destruction unless it is a infection? Or second is rheumatoid, but they don't behave like this.
No, but how long has the pathology been? It's been a child since she's been limping from childhood, or it's been a recent pathology.
It was not a childhood problem, but like a few years problem. Patient was having mild pain, then it was progressing, and at this stage, the patient is having severe pain. They are worked up for the infection, and it's all negative, and this is what it has been. So, okay, for all practical purpose, the discussion, it's all no infection, no other problem. It needs a THR.
No, there is no question. It will need THR.
Yes.
But if
So-
it is infected, we will think of
It's not infection.
two-stage. Or if it is a tubercle, we will think of starting anticox and getting a biopsy, whatever is.
Okay. So, Dr. Mahajan, any implant choice?
Yeah, I would go for they use the head as a graft, put a pinnacle or gription cup, what I use normally,
Yeah.
and a coral stem.
So
There's
you
nothing
mean to
else.
say there is a good bone loss, good
Yeah, of
amount
course, so
of
you can
bone loss. So
pack
we
the
have to
head.
be very careful in
Yes.
that. The bone is
Protrusio.
soft. The bone is soft. We have to be judicial in reaming. Already there is some protrusio. So many things are there. It's not a simple case. So this is what infection needs THR. Oh. Okay, sorry, there is some juggling around. I will come back to this case. Sorry about that. 45-year-old male, dull aching pain, both hips, 3 years, morbidly obese, diabetic, chronic alcoholic. This is the X-ray. Quick options, Dr. Hari.
Well, I mean, since he's a long-standing alcoholic, I would just want to make sure he doesn't have osteonecrosis, but it looks like he has femoral acetabular impingement as a cause of his pain. But,
No, you got head changes. It's most likely avian. Yeah.
Yeah. So MRI report shows avian. So yesterday we had a discussion about this stage 2, stage 3, what will you do? So this is the X-ray. Patient is having pain both sides, more on the left side. Dr. Bose, at this stage, what will be your management for pain and AVN?
Well, if it is symptomatic and then he has got already some OA changes, there's AVN in the femoral head. If the symptoms warranted, then I would offer him a hip replacement.
Okay. So anybody else will differ quickly in this option.
He is eventually going for hip. Timing is ours. You can try, since the sphericity of head is reasonably okay, you might try a bisphosphonates, all those things. Maybe buy time, get his weight loss and do a
So it's
THR.
a dull aching pain. I mean, you never told that it's a severe pain. So let him buy the
The
surgery.
dull aching pain started over the period of time. For 3 years he was having, now he is having pain in the left side. More pain on the left side. No.
So that's on the side of more pain, we can replace it.
Yeah, that's what. My point is, any other options like, okay, right. That is the thing. So the surgeon did a bilateral core decompression, same sitting for both sides for this case. So in almost 6 to 7 months time, this has happened.
So it's progressed. Oh my God, look, these are a
No,
lot of
yeah,
acetabular
like
changes.
this is what the patient comes to you after 6-9 months after core decompression.
Yeah, go to the previous X-ray. The most likely he didn't have AVN on the right side for sure. 2 years. Now, any MRI report in our country, they say when there is signal changes in the subchondral region, they say it's the AVN. But that's just early OA. He's got impingement as early OA, and he's had a core decompression for non-AVN condition. Yeah, that's I find very common. Non-AVN conditions get core decompression in our country.
That is also a very, very valid point. So
Sursil of this patient, the sursil, it is an arthritic hip because sursil is too long, and plus what Vijay commented, osteophyte formation is already started on the lateral side. If you see the sclerosis,
okay.
so this is another
So
important thing.
now how will you proceed, Dr. Mahajan? Like patient is having
I
again,
think this is, my choice is 100% infection.
how will you proceed?
I think 2-stage. Here, we exercise the neck, remove all the debris, put a spacer, and then wait for it to heal. Both sides to be done, of course. Remove the
So how
graft.
will you? So you said two stage.
Of
So,
course, both sides to be done. Stage 1 and then stage 2.
in same sitting, simultaneous, you will open both sides and do a
Yeah.
two
We
stage.
must remove all the graft.
Dr. Hari?
I agree that infection's on the top of my list because of all the acetabular changes here. And you should, to stage him, I mean, it's difficult because both are so destructive and are horrible. So I would do the single procedure on both sides at the same time.
Dr. Bose?
Yeah, if I don't have the bug, then I'll certainly stage it. So just like Mahajan said, I would do both sides together, cement spacer, and then I'll come in for the THR later.
Rajkumar, before that, I would like to get his MRI. If there is a fluid or anything, I will get the aspiration.
so the-
Before proceeding, I must confirm this.
So 3 important points out of this is the experts, they have very clearly brought it out that when you see an X-ray like that, chronic alcoholic obese patient having a X-ray like this, don't even think about anything else. That is a point number 1. You have to treat it as an infection. Point number 2. And these kind of situations, don't hesitate to take an MRI. That is again a very, very valid point. Both hips, something going on in the pelvis, might be something in the above also from in the psoas region. So we have to be very, very careful. So as usual, the blood parameters, it is elevated, ESR, CRP, elevated. So in these kind of chronic alcoholic patients, please also do ultrasound, LFT, be prepared, make sure your workup is proper, counsel the patient, and definitely there is no role for primary THR. The debridement and cement spacer is the most So this is what perioperative. The moment left side, he was not very keen on the right side initially because his more pain was on the left side. So when I opened, this was the picture. So it was very obvious that there is, so debridement done. Okay, so underwent debridement, cement spacer application for the left side, pus tissue sent for all the investigations, gene expert, biopsy, everything. And this is the post-op that time, during that period, I used to use these kind of cement spacers, but now I have completely moved to static, as Dr. Bose was mentioning. So the reports came like this. All the cultures negative, gene expert negative, gene expert alone positive, weekly, very low level, no biopsy normal. Yes.